Hi, everybody. Welcome to OsteoBytes, and thank you for taking an hour out of your day to join us. My name is Christina Iptoma, and I am mom to OsteoAngel Dylan and Director of Scientific Programs at MIB Agents. And today on OsteoBytes, we are joined by Dr. Kristen Van Heijs from UH Rainbow Babies and Children's Hospital in Cleveland. And we are really looking forward to this overview and update on a phase 1/2 multi-centered, multi-continental trial to assess the safety and efficacy of Bactosertib in adolescents and adults with recurrent, refractory, or progressive osteosarcoma. Thank you so much, Dr. Van Heijs, for joining on OsteoBytes today. We are thrilled to have you. And also thank you to our panelists joining us today, Kerrigan and Walker. A little bit more about our guest today. Dr. Kristen Van Heijs is a pediatric hematologist, oncologist, and a translational therapeutics-oriented physician scientist. She completed her clinical fellowship in pediatric hematology oncology in 2019 and was appointed assistant professor of pediatrics at Case Western Reserve University School of Medicine at that time. And she has been a member of the Alex Wong Laboratory since 2017. Dr. Van Heijs has focused her research efforts on understanding the role of the tumor microenvironment in osteosarcoma and how immunotherapy could be a novel therapeutic option for patients with this disease. She's also the principal investigator of a phase 1/2 multi-centered clinical trial designed in collaboration with MedPacto for patients with osteosarcoma, and we're going to be talking about that trial today. And for these efforts, she was a recipient of an NIH K-12 award, as well as multiple foundation awards from Hyundai Hope on Wheels, Cure Search, and Cure Childhood Cancer. And MIB Agents is proud to have supported her work with a 2022 Outsmarting Osteosarcoma Young Investigator Research Grant because of Charlotte. And she is currently a member of the Children's Oncology Group Bone Tumor Committee. So welcome, Dr. Van Heijs. Very excited about this topic today. I think there's a lot of interest in this trial. Just a couple of announcements before we get started. Our next virtual tumor review board, which we call Turbo, is May 8th at 5 Eastern. And if you're a clinician interested in attending or presenting a case, you can email me at christina@mibagents.org. And we also welcome researchers to this educational forum, as it's a great opportunity to learn about real-world clinical challenges. And I do have to put in another plug for Factor. It's coming up in, less than 2 months. And registration is filling up really quickly. We are definitely going to sell out this year. So if you are planning to attend, definitely register. There is a lot going on at Factor this year. We have over 10 scientific panels. We have our wellness session tracks that are back. Some highlights include Max, one of our junior advisory board members, will be teaching a crochet class. The very popular sound bath is going to be back, as well as our therapy bunnies. And I mean, there's really something for everyone. We have the Warrior HQ. Walker, I know you're going to be there. Kerrigan, would love to see you there. And we're going to have a Healing Hearts workshop in person. We have a family fund reception. We have so much going on. So there really is something for everyone. So I will put some info in the chat about how to register or just find more information on that. Oh, Ashley, the thing I really wanted to mention is that there's going to be a prom this year. That's actually new. And we're super excited about this. I think it's Enchanted Forest theme with a little bit of Candyland thrown in. So like, maybe you didn't go to prom the first time around, or maybe you went and it was a disaster. So this is like your second chance to capture your perfect prom. And there's going to be a DJ. There's going to be, like the little prom photo thing. So, if the scientific sessions and all that stuff isn't like enough of a reason to come, there's prom. So I hope we see you there. Kerrigan, can you go ahead and introduce yourself?
Yes, of course. I am 23 years old and I've been fighting cancer since I was 18, and I'm above the knee amputee. Singing is definitely a passion of mine, as well as advocating. And I went to Factor 2 years ago and it was amazing. And so did my parents, and they learned a lot about clinical trials. And I'm actually looking into the clinical trial that we'll be talking about today. Kristen, you're amazing. And Walker, would you like to take it away?
Yeah, for sure. Hi, my name's Walker. I'm part of this year's MIB Junior Advisory Board, and I was part of the last couple years as well. I got to make it to Factor last year, and I believe I heard a little bit about this research there. So I'm really excited to hear more about that today and a little bit more on, I think, the trial specifically. So with that said, Dr. Van Heist, you can take it from there.
Okay. Hi, everybody. Thank you so much for having me back. I love MIB agents and everything about MIB agents, and I feel like I've known you guys for a few years now, so I'm always like so happy when you ask me to be participating in something. Um, please forgive me if I cough. I had COVID last week, so I'm just still a little recovering from that. And I'm having some technical difficulties at work, so I have two screens open. So if I look like I'm looking away, that's part of the reason. So let me share my screen and see what I can do here.
Well, the feeling
Okay.
is mutual. We're big fans, and thank you for doing this, even though you're just coming off of COVID.
Oh, of course. Okay. You guys can see this? Does this look
Yes,
right?
looks great.
Okay. Okay, great. So as everybody mentioned, thank you for the warm welcome. I'm Kristen. I'm a pediatric hematologist oncologist at Rainbow Babies and Children's Hospital in Cleveland, where Factor will be this year. So that's another reason to come to Factor because Cleveland's a cool place. And today I'm going to be talking about using a TGF beta inhibitor as a potential novel therapeutic option for treatment of osteosarcoma. Okay, let me see. Okay, so my disclosure information is that I am the PI of a clinical trial that's sponsored actually by MedPacto because the drug that we're going to be talking about is manufactured by them, and that drug is called Vactosartib. And then I'll also be just discussing experiments that I'm currently working on using cryoablation in addition to Vactosartib. Okay, so transforming a growth factor beta. So literature suggests that TGF beta is critical in osteosarcoma development. It's a very potent immune suppressive molecule in the osteotumor microenvironment. Its expression is increased in the serum of osteo patients compared to those of healthy donors. And the production is correlated with high-grade osteosarcoma, and it's also associated with the presence of lung metastasis. TGF beta signaling has also been in myeloid cells to be signaling in myeloid cells is actually required for tumor metastasis. These are just some articles highlighting what I just pretty much summarized on the last slide. So the tumor microenvironment is comprised of a lot of cells. What makes osteosarcoma different, or a lot of solid tumors different from hematologic malignancies, such as leukemia, for example, is that the genetic heterogeneity of osteosarcoma is very different and can be very different from one person to the next. And so it makes a molecular target to osteosarcoma itself rather difficult. And so there's this concept of the environment that the tumor lives and thrives in. And what if we could make that environment less hospitable to tumor cells? And so, as I mentioned, TGF beta is one of the most potent immune suppressive molecules secreted in the osteosarcoma tumor microenvironment. It contributes to the malignant tumor microenvironment through the recruitment and induction of immune suppressive myeloid and regulatory T cells. And then this suppresses the function of tumor reactive cytotoxic T cells as well as natural killer cells. So there have been antibody-based therapeutic approaches to TGF-beta previously. The issue is, so there's several issues. So antibodies that block the receptor for TGF-beta 1, which is what we're going to be talking about today. There's 3 isoforms of TGF-beta 1, 2, and 3, but we'll be talking about TGF-beta 1, are effective under certain circumstances, but there are limitations to its use. So the first is difficulty controlling toxicity. of prior antibody-based approaches, the major one being cardiac toxicity. And antibodies that have been developed before have long half-lives, which prolongs their global inhibition. And I don't know why I wrote that twice, but it prolongs their global inhibition. And so it causes issues for a longer period of time to potentially healthy cells in the body. So what we think is ideally needed is a small molecule-based, orally available, titratable TGF-beta1 inhibitor that has low toxicity and is considered to have higher tolerability. So I work, as Christina mentioned, in Alex Wong's lab. I know he's like a fan favorite too of MIB. He's like so popular. He's a celebrity. And he was my fellowship program director when I was a fellow here in Cleveland. And so I joined his lab in 2017, and I've stayed there ever since when I graduated. I work with several people on this project, Sunhee, Jay, and Suzanne. And they pretty much teach me a lot of what I know because I was not a basic science person before I came to fellowship. So Vactosertib, as I mentioned before, is it's a drug that is manufactured by a company called Medpacto. It's a South Korean-based pharmaceutical company. Anybody who's on the call, who's like a physician, may have spoken to Sarah if they had a patient who was interested in compassionate use. She happens to be like my point person there. And then Sunjin is the CEO of the company. And Vactosertib is a highly selective and potent small molecule inhibitor. It is a type 1 TGF-beta receptor, which is also known as ALK5 inhibitor, sorry. And so of the type 1 receptors, ALK5 is considered to actually be the most specific for TGF-beta ligands. It's orally available, and it's dosed twice daily, 5 days a week. It has 10 times the potency of another ALK5 inhibitor, but with less toxicity. So this, I can never pronounce this name. It's actually embarrassing, but Galonsertib happens to be one of those antibodies that I mentioned before that's been tried, but has significant cardiac toxicity as well as a very long half-life. So Vactosertib has been used in prior studies for adults with different malignancies. And it's been shown to reduce cancer cell migration, invasion, and metastasis in animal cancer models, particularly with respect to lung mets and melanoma. As I mentioned, it's been used in other malignancies for humans in clinical trials. And right now, it's actually currently being used, if you were to look on clinicaltrials.gov, it's actually currently being used in combination with other immunotherapies for patients with melanoma, multiple myeloma, advanced dermoid tumors, as well as GI malignancies. So the hypothesis of the Wong lab was that perhaps targeting TGF-beta in the tumor microenvironment of osteosarcoma could also reduce and/or ameliorate disease. So this is something that these are slides I've presented before at Factor, but I just figured for anybody on the call who perhaps didn't hear my talk, I would briefly run through them. This by no means is at all comprehensive of the work we've done over the last several years, but it's just like a snapshot as to what helped support our thought for the development of a clinical trial. So this slide shows basically the effects of Vactosertib on both murine, which are mice, and human osteosarcoma cell growth in vitro. And so what we did was we incubated murine osteosarcoma cell lines K7, K7M2, 493, and 482. K7 is known to be a spontaneous murine osteosarcoma cell line, with K7M2 being the metastatic form of that cell line with various doses of Vactosartib. And then we looked at cell growth, which was quantified over a 4-day period of time. And what you can see here is that the growth of both the murine as well as the human osteosarcoma cells in vitro were significantly inhibited by Vactosartib in a dose-dependent manner. So the higher the dose of the Vactosartib, the less the cell growth. Okay, let's see. Okay. So this slide is sort of busy. So to determine if Vactosartib could directly affect tumor growth in immunocompromised animals in vivo, we took NSG mice and they were subcutaneously injected with a murine osteosarcoma cell line, and they were treated for 67 days later with Vactosartib via oral gavage. So we treated them 5 days on, 2 days off, which would mimic a scenario in humans. And then tumor growth was measured weekly and survival was also tracked. And what we found was that by day 112, the survival rate of vehicle-treated mice, which is our control group, was only 20%. However, 100% of the Vactosartib-treated group survived, indicating a significant increase in survival rate. To examine the effects similarly of Vactosartib in immunocompetent mouse models, the cell line, the metastatic cell line K7M2 was injected subcutaneously into a BALB/c mouse. And on day 11 after tumor injection, mice were treated with Vactosartib. We usually wait a certain amount of time to start treating the mice just because we want to establish that we actually see tumor growth. And so it tends to take about 10 to 11 days to do that in this scenario. And then mice were treated with Vactosartib at a dose of 50 milligrams per kilogram for 5 days a week. And tumor volume was measured by external calipers. And what we found was that Vactosartib treatment significantly inhibited K7M2 tumor growth compared with vehicle treatment or control group. And 39 days after tumor injection, we euthanized the mice and their tumors were weighed. And then what you can see here is the actual tumor volume of the mice who were treated with vehicle, which is our control group, versus the mice that were treated with Vactosartib. And so this was significantly lower, the tumor volume, than the vehicle group. Okie dokes. So similarly, this is also sort of a busy slide, so I'll try to go slowly. So up on the left here, figure A, we looked at BALB/c mice again, which is an immunocompetent mouse model, and we injected them with 1 million K7M2 cells on day 0. And then we started treating them with either vehicle, which is a control, orally, or Vactosartib. This time we used a dose of 25 milligrams per kilogram orally, 5 days a week, starting on day 7. And what you can see here on the right is we measured the tumors using something called bioluminescence. And so if you just look at the control group compared to the group that was treated with Vactosartib, this is tumor, it lights up. And so what we did was we measured tumor intensity using BLI once a week, and then we graphed this over time. And essentially, what you can see is that the mice treated with Vactosartib at the same points in time had reduced tumor presence on BLI imaging as compared to the control group. And then here on the left is just more of like a schematic, just basically demonstrating what's here, but just in graph form. So we actually can measure the intensity of this signal, and that's what we plotted here, the BLI signal intensity versus weeks after tumor injection between the control group and then the Vactosartib treated group, and even the signal intensity of the tumor was significantly less in the group treated with Vactosartib.
And Dr. Van Heist, just to clarify, so here we're looking at it's more inhibiting growth as opposed to killing tumor cells that are
Well,
already.
we believe that it can actually do both,
Okay.
because most of the time when we treat the mice, we actually treat them after we see tumor growth, so that we're not just, it would be hard to, I think, to make an assumption then that it's like inhibiting tumor growth per se, because sometimes, you know, nothing in like a laboratory preclinical setting is ever perfect in research. And so, you know, we do inject these mice, and sometimes you inject the cells, they don't grow in the right place. You know, there would be a lot of other variables. And so we actually select out mice that generally have tumor already present, that we can measure either by BLI, which is the bioluminescence imaging, or by caliper size, or you can like visually see, so that we know it's there before we start treating. Does that make sense?
Yeah, thank you.
So sometimes we do see like a reduction in the size of the tumor. Sometimes what we've seen is like just not progression of the tumor, or a slowed progression, I should say, of the tumor. And then we did a very similar, the same experiment essentially, but we used the Vactocertib dose, the higher dose that I showed you in the previous slide of 50 milligrams per kilogram, orally 5 days a week. And we did BLI. And what we found then, which is not shown here, is that the Vactocertib was also effective in suppressing tumor growth, even when a mouse had a higher tumor burden. Okay, and then one of the last slides I just wanted to show, this is also kind of busy, I'm sorry, but I'll try to go slowly.
It's because you did a lot of experiments. You did a lot of
Yes,
work.
we did. And I was like, I cannot just, you know, we can't obviously put it all in here. So I tried to pick the ones that summarize things the best. We also wanted to look at the effects of Vactocertib in combination with immune checkpoint blockade. So either an anti-PD-1 or anti-PD-L1 for mice that had pulmonary osteosarcoma. And so what we did was a similar experiment. We used an immune competent mouse model, which was a BALB/c mouse, and we inoculated them with 1 million K7M2 cells on day 0, and then we started treating them with Vactocertib, with and without antibody, starting on day 21. So we actually like let these tumors grow quite a bit, and then 3 weeks later started treating them. And we did BLI imaging again once a week. And basically what we found was that BLI at 11 weeks, this is more looking at figure B here, after tumor injections, wait a second. I'm trying to see here. Okay, yeah. So these colors correspond to what's over here. I'm sorry, guys. I probably should carry that over. And so essentially what we found was that the effect of Vactocertib with immune checkpoint blockade did not actually have any more of a synergistic effect than Vactocertib monotherapy alone. But this was, again, this was not an experiment that we had done multiple times over. And so I'll get to that a little bit later on in the presentation. And I'll also kind of speak to why this was interesting to us in the first place. So based on our preclinical data, which again, like spanned far more than just the 5 slides I showed you, we felt we had enough evidence to support the potential development of a phase 1/2 clinical trial. And so we collaborated with MedPacto to see if they were interested in possibly sponsoring the trial and collaborating with us, since it is their drug, on this trial development, and thankfully they were. And so a few exciting things had happened along the way. Vactocertib actually received FDA organ drug disease status for osteosarcoma in August of 2021, based on the data that came out of the Wong lab. We completed the phase 1/2 clinical trial development in October of 2022. Then the FDA, Vectosertib was designated as an FDA fast track item in January of 2023. And now the trial currently is opened in 4 sites. Rainbow Babies and Cleveland, where I am, is one of the sites. And then WashU in St. Louis, Missouri is another site. And then there are 2 sites currently opened in South Korea. And MedPacto just got approval from the European Union to also open the trial there. And then I believe there are several other sites that will be opening up in the United States soon, down in Florida, CHOP, quite a few places. So it just takes, sadly, a while, but it's very exciting. And then we wrote a paper, all of us collectively wrote a paper that's currently was submitted and is being reviewed, but can be reviewed actually, if you just were to like Google this, so there's like a preprint version you can just read if you're interested.
So also, sorry, just quickly, for
no,
some of those terms like the orphan drug status or the I forget, the fast track status, can you just like, does that have any implication in terms of patient accessibility, or is it more just
so it's more yes and no. So like orphan drug disease designation is usually given to a drug that shows promise in treatment, prevention, or like the diagnosis of like a rare disease. And so osteosarcoma is considered a rare disease. A lot of these approvals from the FDA just allow this process to move a little bit quicker, because to open up a clinical trial actually takes quite a bit of resources. And so if the FDA like buys into it, in my experience, kind of right off the bat, I do think that it enables patients to have more access to the drugs, particularly easier on a compassionate use basis, as well as trial opening, site opening, and etc. I don't know that it like does much else, but I've also only had limited experience just with this trial. The other trial that I'm a PI of is an investigator-initiated trial with a drug that's like already FDA approved for other indications, and so it didn't have these designations. So hopefully that answers your question.
Yeah. So it sounds like it can kind of expedite in terms of making it available through trials and through compassionate. Great.
So the trial, if you guys were to look it up on clinicaltrials.gov, it's a phase 1/2 open label, multi-centered study to assess the safety, tolerability, pharmacokinetics, anti-tumor activity, lots of things of Vectosertib just as monotherapy. So it's used as a single agent in adolescents and adults with recurrent, refractory, or progressive osteosarcoma. So let's chat. So the study objectives, which I don't think I actually ever presented at Factor before, so I kind of wanted to go more into the specifics of the study. So the primary study objective for phase 1 is to evaluate the safety and tolerability of Vectosertib, including estimation of the maximum tolerated dose, which is generally what phase 1 studies are aimed at doing. A phase 1 study is always aimed at just determining what is the dose that is maximally tolerated in this patient population, as opposed to efficacy. That's more of like a phase 2 objective. This would then help us determine the recommended phase 2 dosing and or characterization of dose-limiting toxicities in adolescents and adult patients with refractory, relapsed, or progressive osteo. The primary objective for the phase 2 portion of the trial is to evaluate the anti-tumor activity and objective response rate of the drug in the treatment of patients with this disease. And then our secondary study objectives is to evaluate the overall survival of subjects treated with Vectosertib. And then we have several like exploratory objectives that are more of like a tumor microenvironment based questions, pharmacokinetics, pharmacodynamics, how people process the drug, etc. So inclusion criteria, because I get asked this a lot. So you can either be a male or a female, but you have to be greater than or equal to 14 years of age. However, I'll go into a little bit more specifics. Right now, the trial is only open for ages 18 and up. And hopefully in the near future, it will be open for 14 and up. And we're working toward hopefully lowering that age limit even to as low as 12, based on the data that we get. But for now, I'll explain on another slide why it's 18 and up for now, but it ultimately will go down to 14. So subjects must have a diagnosis of osteosarcoma. They have to have measurable disease based on the RECIST 1.1 criteria. People enrolled on the trial have to recover from the acute toxic effects of all prior therapies, with the exception, obviously, of hair loss, anorexia, bone pain, or tumor pain. They have to have adequate recovery of counts prior to entering onto the study, and pretty much have adequate renal function, no active or acute infections, and they have to have like a good performance score. This is all more like medical stuff that a patient does not have to worry about. Doctors can figure that out. Patients have to have normal organ and marrow function, and we have that defined. And then patients also have to obviously have an ability to understand and a willingness to participate in the study, and a body weight of over 30 kilograms, which is over 62, 64 pounds. So exclusion criteria, we will not enroll patients who have moderate or severe cardiovascular disease for the reasons that I mentioned before. Cardiac toxicity is one of the side effects of these TGF-beta inhibitors, although has not really been shown to be the case with Vactocertib in particular, but just known from other antibody therapy. Subjects cannot have any sort of gastrointestinal bleeding within 4 weeks of the screening process. The screening process usually takes place within 28 days, the 28 days prior to the first dose of the drug. Anybody who has a known history or some sort of suspected hypersensitivity, so basically like an allergy to any part of the drug. People who have received prior TGF-beta inhibitor therapy are excluded from the trial, and anybody who has some other disease or condition that would affect the mechanism of the drug are not allowed to enroll. The drug has to be swallowed whole. It cannot be chewed or crushed. And so if you're unable to swallow pills, tablets, we can enroll you on the trial. I get asked this a lot, which is why I highlighted it in red. Not that it's not meant to be scary, but sadly, patients with osteosarcoma, if they're coming to us for enrollment on a phase 1 trial, they often have been on other investigational products. And so if this has happened within 28 days before screening, or a period of shorter than 5 times the half-life of whatever drug or agent you were previously on, there has to be a washout period. So we know that there's like no confounding factors with you taking the Vactocertib. And then there are several prohibited medications that just cannot be taken when somebody is also taking Vactocertib. And those are on this page. Again, something that can be addressed with any sort of referring physician. But the reason for this is that it can affect the metabolism and excretion of the Vactocertib. Okay, so this is sort of like the overall design. It's an open label, single arm proof of concept trial that is currently multi-continental between here and in South Korea, but hopefully we'll also be expanding to Europe soon. This means that everybody on the trial will get the drug. There's no randomization. There's no blinding. You know what drug you're getting, what dose you're getting. It's transparent in that regard. So the phase 1 portion of the trial, as I mentioned, the purpose of a phase 1 study is to just determine primarily what is the safest dose that we can give to this patient population. And that's determined on this trial, which is a common schema in phase 1 trials, by something using a 3x3 dose escalation design. And so we have 3 cohorts. Each cohort has a different dose that they receive, and that dose increases from cohort 1 to 2 and then 2 to 3. What I mentioned before, why the trial currently is only open for patients 18 and older, is because there's actually 2 separate cohorts, one for adults and one for adolescents. And so right now, the trial is currently being paused for accrual because the Data Safety Monitoring Board at MedPacto is reviewing data before opening up the 3rd cohort for adults 18 and up. So cohorts 1 and 2 for 18 and up have been filled. Once cohort 3 for adults opens up, after that, if it's considered safe to do so, then cohorts 1, 2, and 3 will be opened up for patients 14 to 17. About 6 patients will be enrolled in each cohort. The phase 2 portion of the trial won't happen probably for a while because we're still accruing for phase 1. But ultimately, our goal is to enroll 42 patients at the maximum dose level, including those that were on the maximum dose level in phase 1. So whatever dose we determine to be the maximum tolerated dose from phase 1, all 6 of those patients can sort of roll right over into phase 2. And as I mentioned, the Vactosartan is given twice a day, 5 days on and 2 days off in a 4-week cycle. So each cycle is 28 days long. So I feel like I said this 1,000 times, probably didn't need to write it that many times, but so it's taken every 12 hours. So it really should be every 12 hours. I say that because sometimes, you know, your doctor will say, oh, you can take this at like in the morning and then right before bed. But ideally this you want to be spaced 12 hours apart to maintain that level of drug in your system. And it should be taken with food 5 days a week. It has to be swallowed whole, so it cannot be chewed, crushed. A cycle is defined as 28 days. So in a 28-day cycle, it'll be given days 1 through 5, 8 through 12, etc. Patients are seen the first day of each cycle. I tried to like outline this mostly because patients reach out to me from all over the place, not just Cleveland, actually really not Cleveland at all. And so they're just wondering like how often they would have to travel back and forth, whether they're seen here or at WashU. And so patients are seen the first day of each cycle. On day 1, cycle 1, and on day 1 of every cycle, labs will be drawn, pharmacokinetic samples will be drawn. Pretty much the first day of the cycle is going to be a long day. Patients are seen again on the 5th day of cycle 1, but this is not with every cycle, just the first. And more pharmacokinetic samples are drawn. These are just blood samples from the patient. And then days 3 through 6, during cycles 2 and 5, tumor biopsy and blood pharmacodynamic markers are also done. And this is done also before cycle 1. And this is primarily because people are like, why do I need tumor biopsies? And the whole purpose is, if we do this before you start the drug, and we do it again if you have measurable disease, we can actually analyze. That's the best way to analyze the tumor microenvironment, to see what the drug is or is not potentially doing in that environment. But this is only right before people start cycle 1 and cycles 2 and 5. So for the most part, patients are just seen once every cycle.
So, sorry, can you just clarify how that would work, like in a clinical setting? So let's say, you would have multiple lung nodules and one would be biopsied, and is it like a resected and
Yeah,
biopsied?
if accessible, you know, certainly if for some reason a surgeon or an interventional radiologist or whomever could not get to it, that's not like necessarily a preclusion. It's just that if it's possible to get to, even if it can't be resected, but part of it could be biopsied, that would be our ideal scenario.
Okay.
Because you can only garner so much information from peripheral blood samples, which are, you know, blood that you obtain from a vein, to actually know what's going on with the tumor or the tumor microenvironment. You'd really need to take a piece of that.
And is that like an open?
So it depends. And the only reason why I say it depends is because I personally would not be the one doing it. And so it would be like a surgeon or an interventional radiologist, and it would be a discussion with them, like what would be the best approach. And we're enrolling patients on this study too. I mean, I feel like a lot of patients who come to us often come to us with lung metastasis because that's the most common site for disease relapse with osteosarcoma. But some patients actually don't have lung mets and have like disease elsewhere. And so this study, unlike my other phase 1/2 trial, is not as limiting in the fact that patients with disease kind of anywhere can enroll in the trial. It's not just limited to the lungs. Does that answer your question, Christina?
Yes.
Okay. So, and then duration of treatment and treatment assessment. So we will look at tumor response with either imaging, with imaging, with either ACT or MRI, whatever is preferable based on the location of where the disease is. And this is done every 2 cycles, so approximately every 8 weeks for the first 24 weeks, and then every 3 cycles thereafter until there's tumor progression. The RECIST 1.1 criteria is a criteria that oncologists use to determine what's considered measurable disease. And so this is not something like a patient needs to concern his or herself with. But this helps us to define what is disease progression. So a patient, even if there is some sort of defined progression, a patient can still continue to receive the study treatment, and then we will re-image the patient 4 to 8 weeks later. But a patient cannot continue on the study if the disease progression occurs after there's already been considered a complete response or a partial response in a target lesion. The reason for this is sometimes patients can have what we call pseudo progression in certain scenarios. This happens frequently after radiation therapy. This happens frequently in patients who receive antibody therapy, where their imaging looks as though they've had disease progression, but in actuality, that may not be the case. So that's why a patient, if they appear to have disease progression as defined by this criteria, can still receive the drug, and we'll just re-image them 4 to 8 weeks later. But if they've already shown some positive response and then have progression, they would be removed from the study. And there's really no, I should just mention, there's really no end point to the study. So long as someone is having either, you know, stable disease or certainly some sort of a partial or complete response, they can remain on the drug. It's not like, oh, we're going to stop this in 5 months, you know? So, and just to mention, Christina, I know knows this, but we've had many patients because it took a while to open this trial. The company has been very willing to provide the drug on a compassionate use basis. So this is for patients who perhaps needed to be on the drug or wanted to try the drug, but could not enroll on the trial because either the trial wasn't open, or this is for patients who otherwise do not meet inclusion criteria to be on the trial. And the company will provide it on what we call a compassionate use basis or a single patient IND basis. And while it's very difficult to say anything about the patients who have received it on a compassionate use basis, only because it's not like a structured format, like a clinical trial where everything is highly regimented. And so some patients get the drug and their disease sadly has progressed so far that by the time they get the drug, they may only live another week or two. But there have been patients where it seems to potentially have provided some benefit based on historical control of like, hey, this patient has X, Y, and Z, and normally patients with X, Y, and Z would progress or relapse within this amount of time, and this patient didn't do so until this amount of time. And so we have had patients on compassionate use of the drug for quite a while. Not everybody, but I am aware that both here in the US as well as in Korea, that has been the case. So I think the more patients that we're able to actually get regimented information from and data from on the clinical trial would be most helpful. So if you go on clinicaltrials.gov, every site has a site PI, but I'm like the PI of the whole trial. And so my contact information is listed there. This is my email address. I'm pretty responsive to email. So you can feel free to shoot me an email and then I'll get back to you as soon as possible. And I'm always happy to talk via phone, Zoom, whatever, smoke signals with patients as well as physicians. And then these lovely people are our pediatric clinical trials unit here at University Hospitals, Rainbow Babies and Children's. And so this is their email. So even if you can't reach me or you don't want to email me, even though you'll talk to me anyway, you can reach out to them and they'll be happy to help you. Unless, of course, you're located closer to Missouri. If you want to reach out to them, you can do so as well. And so because we were so excited about all this like promising, potentially promising data, 2 other projects that I'm working on right now in the lab with Sung-hee and Jay and Suzanne are to look at the immune-mediated anti-tumor effects of Vactocertib and its synergy with immune checkpoint blockade, because as I mentioned earlier, it didn't seem to be very synergistic compared to Vactocertib alone. But we want to do this actually in a humanized immune mouse model where we try to make the immune system in the mouse that of like a human's. And that way we can inject human osteosarcoma cells into the mouse and treat them. This is what my CureSearch Award is funding, helping to fund. It's very time consuming and very tedious to create these mice and then to keep them alive. And so we have just very prelim data and we're trying to kind of finesse our experiments for the next go around. And then the other one that we're working on, which is not quite as time consuming to get results, I should say, is the combination of cryoablation and Vactocertib. So this is just touching a little bit on the humanized immune mouse model. This is what we've done in the past where we used NSG mice. We irradiated them. We injected them with CD34 positive hematopoietic stem cells. And then we looked for engraftment based on circulating peripheral blood CD45 positive cells. We've come across a few issues during this experiment and some things that I think would raise concerns, not concerns, but just like questions like, well, how do I really trust this data, et cetera? And so this is what I mentioned that we're trying to finesse right now, but I still think it'll be really cool once we do that, just to see what the results are. And then this is just talking a little bit about what I said. What we're trying to use in this humanized immune mouse model is actually a c-Myc amplified human osteosarcoma cell line. In general, patients with osteosarcoma whose tumors are c-Myc amplified tend to have a more aggressive form of the disease than those who do not. And so we want to sort of exploit this using this humanized immune mouse model. So that's that. And then my Cure Childhood Cancer Award, which I recently got as well, is helping to fund this other project looking at cryoablation in combination with Vactocertib. So cryoablation, for those that don't know, is an established alternative to surgical debulking of inoperable tumors. It's a clinical intervention where basically a probe is used with very, very cold temperatures. And it's either with argon gas or liquid nitrogen, and it's passed into the tumor. And then tumor cells are damaged by the formation of liquid crystals. This enhances anti-tumor immunity, and it can result in the reduction of both the tumor that was treated as well as distant tumors. And that's called the abscopal effect. So you treat one tumor with cryoablation, it can reduce the size of that tumor, but it might actually also reduce the sizes of other tumors that you didn't touch with the probe. And so this has garnered a lot of interest with cryoablation. And there's actually a trial that was at Children's National Research Institute. It says on clinicaltrials.gov that it's active but not recruiting, where they were looking at dual checkpoint inhibition with nivolumab and ipilimumab and cryoablation in patients with relapsed refractory pediatric solid tumors. And so in Alex's lab, we're currently looking at preclinical murine models with osteo, and we're treating them with cryoablation alone and then cryoablation in combination with Vactocertib versus Vactocertib alone. And, you know, our data is pretty preliminary, but there's some hope there that perhaps this has some sort of synergistic effect. And then I would be remiss if I didn't mention this because Alex is the director of our Center for Pediatric Immunotherapy here at Rainbow. Rainbow's a cool place. And we have a lot of resources here that I think really help us to be able to move a lot of this research forward. And so I'm very thankful to benefit from that. We're just trying to get the word out there. So like spreading the word about these things. MIB Agents has always been so supportive of doing that. And I hope I can come to Factor this year. I'm just on the inpatient unit as the attending that week. So that's sort of a bummer, but I'm going to try to get out of it and, or switch things. And, but recently, Dr. Huang and I were on WKYC, which is the NBC affiliate here in Cleveland, talking about the trial. So that they published like a little ditty and then this like video, half of which like was fake. Like I don't even know the patients or the doctors in the video, so they were clearly actors, but it was still cool nonetheless. There's been some articles published, and then I was invited by Poetic, which is the Pediatric Oncology Experimental Therapeutics Investigators Consortium, to present at their winter meeting this year. And I'm trying to collaborate with Allison Pribno. She's a pediatric oncologist in California on the development of another clinical trial. So we're doing some cool things, and hopefully someday somebody out there doing cool things will come up with something that helps patients with osteo. And so I just want to, I'd be remiss if I didn't mention the Huang Lab. I'm always so thankful to them for their patience and for always wanting me to learn more and entertaining me and my questions. And then funding, I was blessed to have received funding from MIB Agents because of Charlotte, CureSearch, Cure Childhood Cancer, Hyundai Hope on Wheels, and I was on a NIH K-12 when I first became an attending for 3 years. So thank you so much, everybody, for having me. I appreciate it.
Thank you. Thanks for the great overview, not only of the kind of preclinical rationale, but also just the mechanics of the trial for folks that are interested in enrolling. And I know we have a bunch of questions that have come in. Walker, do you want to go ahead and take the first one?
Yeah. So the first question that came in says that you showed data to the 6-week mark, but what about later? Like, what did you have any data from after that? And then they said they're asking that because we know that osteo can become resistant.
Yeah, so that's a great question. So we in our humanized immune mouse model, yes. The problem is we actually have to sacrifice the mice at a certain point in time. And we were probably doing it a little sooner than necessary. So to answer that question, the experiment that I'm currently working on in the lab, we are just letting them go for as long as possible. Mice with osteosarcoma, just in general, whether they're treated or not, don't necessarily live particularly long, particularly the control group versus the treatment group. But yeah, this time around, the last several months when we've done the experiments, I mean, we've let them go longer. And so that's the data that we're looking at now.
Okay. If you're allowed to share, what has been like the outcome of that? Have you seen anything different beyond the 6 week mark, or has it been about the same?
It's hard to say. The control group tumors for sure just keep going up. We do see pretty much stability right now of tumors treated with Vactocertib. In the cryoablation and TEW group, it looks, TEW being another name for Vactocertib, it looks as though at some point the tumors might be starting to take off slowly with Vactocertib alone versus the cryoablation with Vactocertib, which is why I mentioned we think there may actually be a synergistic effect with that. With the RNA-seq of the tumors, yes, we are doing that. That's the next question. And so even with the experiments we're doing now, it's a pretty big production after we sacrifice the mice, we harvest tumor cells, we look at all these different variables. And so that's like constantly ongoing in the lab. So to answer your question, perhaps with the cryoablation and the TEW, that's why I said there might be some more promise there than even just with the TEW alone. But it's probably too early for me to say that without replicating the experiment a few more times.
Yeah, yeah. Either way, that's very exciting.
Mm-hmm.
Yeah. Kerrigan, you want to take the next question?
Yes, I had a question. If you're on state insurance, do you know if that would cover the trial? I know the trial that I'm currently on is being covered by the trial.
Yeah, so the issue with these clinical trials, like so sadly, is that MedPacto is sponsoring the trial, so they are paying for anything that it would not be considered standard of care for the trial. So the drug, any of these other exploratory objectives that we're doing, the PK, PD data. The trial, the imaging, because we would normally image patients anyway with osteosarcoma, that is not being paid because that can be paid by insurance. It's considered standard of care.